All right, folks, I hope you can see my slides and hear me. Give me a thumbs up if you can. So this is a little bit of a continuation of what Russell did back in March. So he was covering sleep hygiene and CBT for insomnia. And we thought, we wanted to get into a little deeper into some of the meds. And so I just have three objectives for today. One is to list a review of symptoms for insomnia in patients with opiate use disorder specifically, talk about the use of some non-controlled medications for the treatment of insomnia, and then discuss the pros and cons of the controlled substances for the treatment of insomnia. So that's my basic gist for this afternoon. I wanted to start with this picture. I don't know if anybody knows who this is. The name of the painting is called Sleep, and it is by Jean-Bernard Ristow. I'm not French, I don't know how to pronounce that name. But interestingly, as I was on the internet trolling around, I found out that this painting is at the Cleveland Museum of Art. So the next time I go to the Cleveland Museum of Art, I am going to try to find this painting. So any takers? Does anybody know who this is? Maybe not. Okay, it is Morpheus. So Morpheus is the god of dreams, and I got so interested in this that I had to give you some information about Morpheus before we start talking about sleep. So apparently, Morpheus, according to the Greeks and the Romans, he was the one who shapes and forms your dreams, and he could come to people in any form. He is the messenger of the gods. He's able to communicate divine messages to sleeping people. He can take any human form, but his true form is that of a winged demon. And he actually slept in a cave full of poppy seeds while he was shaping the mortal dreams, which is interesting. And there are some statues that depict him having a winged ear, one winged ear. And so you can see that picture right there. And that symbolizes that he listens to dreams through his regular ear, and then he delivers messages from the gods through his dreams with his winged ear. So that's fascinating. I think Morpheus also has a very amazing pedigree. His father is Hypnos, the god of sleep. His mother is Pasithea. I'm not sure if I'm pronouncing that correctly. And she's the goddess of relaxation and rest. What a nice goddess, right, to get to know. And then Morpheus had two brothers, looks like Phobetor and Phantasis. And Phobetor is the one who creates our nightmares and our phobic or scary dreams. And Phantasis sort of creates our unreal or fantastic or phantasmic dreams. And so Morpheus and his two brothers were known as the Onoroi, which stands for dreams. And interestingly, Morpheus's grandmother is Nyx, the god of night, or the goddess of night. And his uncle is Thanatos, who is the god of death. So I learned all kinds of interesting things about Morpheus. And the reason I bring it up is because we're dealing with opiate use disorder patients who are addicted to morphine, because we know that heroin gets broken down into morphine in the body. And so morphine, the name was coined by a German apothecary named Friedrich Serturner, who lived between 1783 and 1840, and he directly referenced the Latin Morpheus, which is the god of dreams. And it is so called because of morphine's sleep-inducing properties. So I guess the reason that insomnia is a problem for 100% of my patients is because all of them have been addicted to something that induces sleep. So when you take away the thing that induces sleep, now don't be surprised if they all have sleep problems. So that's my little history lesson for the day. And it was just so much more fun than looking up stuff about medications, let me tell you. So I love the Greek and Latin and the gods and the goddesses and all that fun stuff. So that was really cool. But anyway, here's my brief review of systems for insomnia in opiate use disorder patients. So, whoa, those slides are going fast. So I think about it in terms of 4 buckets of questions. What's going on environmentally? What's going on medically? What's going on psychiatrically, and what's going on in terms of alcohol and other drugs. So when I'm talking to my patients about their insomnia, I'm trying to figure out from an environmental standpoint, what is their sleep hygiene schedule? You know, are they looking at their phone until 2 in the morning? Well, yeah, that's why you can't sleep. Do they sleep and wake up at totally different times every single day? Yes, that's why you can't sleep. Do they work 3rd shift? So is their circadian rhythm off balance? Are they under a lot of anxiety and stress, whether that's acute or chronic? Medically, I'm looking for medication side effects like stimulants, steroids, I'm trying to figure out, do they have or might they have sleep apnea, COPD? Do they have something like acid reflux, which is kind of waking them up? Do they have chronic pain? And I'm also remembering that I forgot to add under environmental, how much caffeine are they drinking? So, if they're drinking, 2-liter bottles of Mountain Dew every day, that might be the reason they also can't sleep. In terms of psychiatric, if they have untreated depression, mania, or if they have PTSD that may or may not come with nightmares, that's also going to affect their sleep. And then obviously, if they are using alcohol to intoxication, or if they're always withdrawing from drugs, or if they're in post-acute withdrawal. And I also don't want you to forget that they could be in nicotine withdrawal in the middle of the night. And that's what's waking them up every hour on the hour. So this is the things that go through my mind when my patient walks into my office and says, yes, Dr. Chris, I can't sleep. So I start to immediately go through this list of things in my mind. Here are my Dr. Chris's fave questions about insomnia and its treatment. So I like to start very simple. How long has this been going on? So if my patient says, I have not been able to sleep since I was 12 years old, well, then that's going to tell me something different than if the person says, look, it's been about 5 or 6 months that I've been trying to get sober and I haven't been able to sleep for 5 or 6 months. If the person hasn't been able to sleep since they've been 12 years old, then it's a chronic problem. And maybe they need to get a sleep study, and maybe they've got like 5 or 6 different issues going on. But I always like to ask, how long has it been going on? Because many of my patients have had chronic sleep problems their entire life. And a lot of them discovered opiates, discovered that opiates/morphine, brought them to the god of dreams, and they loved it. And so that's part of the reason they fell in love with their opiate, is because it helped them sleep, even from the age of 15 when they couldn't sleep. And then I like to ask them, what non-medication methods have you tried, right? Have you tried an app? Have you tried sleep hygiene? Have you tried taking the TV out of your bedroom? Like, what have you tried? What medications have they tried? And it's not just what medications have you tried, but I need to hear about the medications. What dosage did you take of trazodone? Did it work? How long did you take the trazodone? Why did you stop taking the trazodone? And I do that for the 10 different medicines that they've tried for sleep. So yes, you have to go digging and find out the answers to these questions. And then of course, because I'm a psychiatrist, I focus on mental health. If they have an untreated mental health condition, i.e. depression, their sleep isn't going to get much better until their depression is well treated. So it's okay to give them medicines for insomnia, but if you're not also giving them 200 milligrams of Zoloft for their bad depression and their bad PTSD, it's not going to do much good. So you've got to treat the mental health condition as well. And then obviously, how early or how good is the recovery that they're in, right? So if they're like in first 2 to 3 to 6 months of sobriety, they're going to be in post-acute withdrawal. So I have to do reassurance, and I have to tell them, you're going to sleep like crap for the first 6 months that you're sober. And you just have to realize that. And there's things we can do, but it's not going to be perfect, because remember, you were addicted to something that is one of the best things that we know for inducing sleep, i.e. morphine and its relatives. And then finally, I always do some digging about, is one of the reasons that you cannot sleep is that you're afraid that you're going to have your PTSD nightmares, or you have your PTSD nightmares and then you wake up screaming in the middle of the night. So again, I'm sure there's other questions. I'm interested to know what your fave questions are about insomnia. Is there something that you pick out specifically to make sure and ask? That kind of thing. So, but I do like to get the details, because otherwise I can't really help them. All right, next slide. This is the slide I stole from Russell's deck from March. So these are the sleep hygiene things. Oh, wow, it's going fast. Hang on, let me go back. Oops. Okay, so these are the sleep hygiene things. I'm not going to read them to you. Most of us know these things about caffeine, excess. Oh God, I should have taken away the about caffeine and excess liquids, and don't use the bed for anything but sleep or sex. Don't watch TV, etc., etc. So I'm not going to go there. What I wanted to focus on is the meds. So here's another slide from Russell's presentation. These are the general recommendations for insomnia. These recommendations are not specific to people with opiate use disorder. So you will notice that these things all talk about controlled medications. So whether it's the American Academy of Sleep Medicine, or the European Sleep Research Society, or the American College of Physicians, they all talk about things that are controlled substances on this list. Now, not everything on here is a controlled substance. So they talk about doxepin, rosarum, antidepressants, doxepin, rosarum again, but everything else they're talking about is a controlled substance. And you'll also notice that they say, don't use anything for more than 4 weeks. Well, I don't know about you, but I have my patients on their sleep meds for like 4 years. So they just can't sleep without taking their medicine. So your patients might be lucky and they might be able to get to sleep after 4 weeks. Not so with my patients. So yes, these are the general recommendations for insomnia. I don't think they fit, for the most part, for the patients that I treat. Now, again, if you guys have other experiences, that's why I'm on this echo, is to learn as well from you guys. So the non-controlled substances that can help with insomnia, they come in 5 classes. And you'll notice that everything on this list is being used off-label, except for the 2 that I have bolded and starred. So the 2 things that you can use that are on label for insomnia are Ramelteon, also known as rosarum, and that's a melatonin receptor agonist. It's an agonist at the melatonin 1 and the melatonin 2 receptor. There's always 2 receptors, I don't know why. And then the other one you can use is doxepin, which is an old-time antidepressant, but it also is FDA approved for insomnia. And what's interesting, and I haven't tried it yet, I think mostly because of expense and it's not covered by insurance companies, is there's a 3 milligram version and a 6 milligram version that is the brand name. And I've just been using the old antidepressant, that's the 10 milligram version. So as I was preparing for this talk, I thought maybe I've been overshooting on the doxepin. So, but anyway, let me just go through these 5 classes. And this is roughly the order in which I would try them in my patients, right? Roughly the order. So I like to start out with stuff you can buy over the counter, like melatonin and related medications. Now, obviously, Ramelteon, you'd have to get a prescription for. Then most of my patients have already tried the antihistamines, the Benadryl, the Vistaril, and then the one that all the OBGYNs use is the doxylamine. I don't use as much of doxylamine because I'm not an OBGYN, but every OBGYN gives this one to their patients. So definitely is safe. If it's safe in pregnancy, it's safe for everybody. I just don't know how well it works. So if you guys have experience with doxylamine, I'd love to hear about it. There are then 5 very sedating antidepressants, mirtazapine, which is also known as Remeron. And the thing to remember with Remeron is that the lower the dose, the more sedating it is. So 7.5 milligrams is way more sedating than 15 milligrams, is way more sedating than 30 milligrams. And so patients, they think that you're underdosing them when you start with 7.5. So you just have to educate them that 7.5 of mirtazapine is way more likely to get you to go to sleep than 30 milligrams of mirtazapine. And that's because at the low doses is when it's basically an antihistamine. So then it kind of like bumps up into the category above. And then there's nortriptyline, amitriptyline, and trazodone. So those are all very sedating antidepressants. And you're not giving them in doses that you would give for depression. You are giving them in sleep-inducing doses. So sometimes people think, well, if I give my patient 25 milligrams of trazodone, that should be enough for their sleep and their depression. Absolutely not. You might need to give them 25 milligrams of trazodone and give them a nice dose of Prozac or whatever other antidepressant you're going to use for their depression. And then there's a class of blood pressure medicines that you can use, specifically the clonidine, which 95 to 100% of your patients have already taken because everybody gets that in detox. And then if they have PTSD nightmares specifically, then I think there's a case to be made for using Prazosin. And then finally, there are the low dose antipsychotics like Seroquel and Zyprexa, okay? And what I mean by that is I use them in low doses. I don't use them at the antipsychotic doses. I use them at the anti-anxiety or sleep-inducing doses. But again, everything that's not starred on this slide is off-label, okay? Everything that's starred is FDA approved. And then there are the controlled substances that can help with insomnia. And every single medicine on this piece of paper, on this slide, is a DEA Schedule 4. So this is a controlled substance 4, which means it's below all of the narcotics like Percocet, which are all Schedule 2 now, and it's below buprenorphine, which is Schedule 3. So these are Schedule 4. So these are weak ones. So the benzodiazepines, right? So we know that benzodiazepines work as positive allosteric modulators on the GABA A receptor, which basically means that they modulate the GABA A receptor which induces the influx of chloride, which inhibits all the activity in the brain, which helps people go to sleep. So that's how that works. And you've got a lot of medications that you can use, from quazepam to triazolam to estazolam to tamazepam to flurazepam to lorazepam, okay? So those are the ones you could choose from. We also have the Z drugs. And what are Z drugs? They're non-benzodiazepine GABA A receptor agonists. And so we have 3 of them on the market: zolpidem, which is known as Ambien, S-zopiclone, which is known as Lunesta, and Zaloplan, which is known as Sonata. And then finally, there's a brand new C4 medicine out on the market, which is called Adora. That's a fun name. It is a dual orexin receptor antagonist, so it's Adora, and that means that it works at the orexin 1 and the orexin 2 receptors. So orexin 1 and orexin 2, well, I should say orexin, right? When there is orexin around, orexin keeps you awake. So if you have an orexin receptor antagonist, you're blocking that receptor, so that's going to put you to sleep. And that's known as suvorexant, also known AKA Belsomra, Belsomra. So this one is unique because it doesn't work at GABA, it works at a completely different receptor. So just wanted you guys to know about that. So that's all well and good, but what do I do on an everyday basis? You may or may not care, but just in case you are interested, and I also want you to share with me your go-to meds for insomnia. This is my list of go-to meds. So with the melatonin family, I will either go regular melatonin, which you can buy over the counter, 3 to 10 milligrams at bedtime. So sometimes 3, sometimes 6, sometimes 5, sometimes 9, whatever size they can get from their pharmacy. I'll go 3 to 10. And then I recently found out from one of my fellows, Dr. Liggett, he said, no, Dr. Chris, you should be prescribing melatonin sublingual. It works thousands of times better. I'm like, okay. So in the last 30 days, I started to prescribe melatonin sublingual, which is 1 to 3 milligrams. The other thing that I know about melatonin is that if you're using it to fix your circadian rhythm, you ought to be taking it at dinner time, which is approximately when the sun sets, except if you live in Northeast Ohio, because the sun never seems to rise. It's always gray. But if you live in a place where the sun comes up and down, then you ought to be taking your melatonin at dinner time, which I think is kind of a mistake that a lot of people make because they tell their patients to take their melatonin at like 9 or 10 p.m. So I've also been sort of coaching my patients to take the melatonin at dinner time, and it'll work better. The second medicine, or my other go-to medicine, is Benadryl or Vistaril 25 to 50 at bedtime as needed. On occasion, I'll go up as high as 100. I will also use the Doxepin 10 milligrams. I will use Elavil 25 to 50 milligrams at bedtime. I'll also push that up to 100 sometimes. Trazodone, I like to stay in the neighborhood of 25 to 100 milligrams at bedtime. I have been known to go up as high as 300, so I probably have 3 or 4 patients that are on that high of a dose. Over 300, you're not really getting much more from the trazodone, and it's super duper. It gives them like the groggy hangover that a lot of the patients hate. So, but some people love it. I mean, some people swear by trazodone. And then I will often go to clonidine, either 0.1 or 0.2 at bedtime as needed. Now, I want to be clear. I'm not giving them all 5 prescriptions. I'm picking and choosing. This is my favorite list of go-to medicines. So I'll usually start with one. Sometimes I'll augment with a second one. And then if they have PTSD nightmares, I will take any one of these 5 drugs on this list, and then I'll add prazosin anywhere from 2 to 10 milligrams. Although I must say I have one patient in my practice who is doing beautifully on 20 milligrams of prazosin. I've never had anybody on that high a dose of prazosin. That, to me, I thought that was kind of crazy. But when I started to read some of the VA literature, they actually did go up to 20 milligrams, so I didn't feel so nervous. But sometimes we'll throw some prazosin or prazosin at somebody and they'll give up at 2 or 4 milligrams. And I would sort of say, push it. See if you can push it up to 5 or 10. It might work for the nightmares. So that's just, again, that's just me in clinical practice. So I have another slide for you, which is my Dr. Chris's pushed against the wall meds, which means, okay, if all of my go-to meds didn't work and now I feel pushed against the wall and I've tried 6 meds and they're still not sleeping and it's horrible, then I will consider the antipsychotics, or I will consider Belsomra. So with the antipsychotics, I'll give you a little bit of Seroquel, 25 to 50 milligrams. That's usually all it takes. I do have some patients in my practice that need up to 200 milligrams. With the Zyprexa, I go 2.5 to 5. If pushed, I will go up to 10. And then the Belsomra, I've probably prescribed Belsomra a total of 4 times now in the last year. I'll go 5 or 10, but it also comes in a 15 or 20. So I will also feel free to go up that high if I need to. I do have one patient out of my 4 patients for whom Belsomra has been the miracle drug, and she's probably tried 7 things to help her sleep, and Belsomra is actually working. So it's been interesting, and so I'd love to hear your Belsomra experiences. I really hate, dislike, do not like the Z drugs. They cause my patients to sleepwalk, sleep talk, sleep eat, other kinds of bizarre behaviors, disrobe and just act crazy. If, however, I am pushed to the wall, I may go to Ambien 10 milligrams, but with lots of warnings that, this is a GABA drug, it's a controlled substance. There is a very, very low risk that you can get addicted to it, so you got to be careful. And then again, I really do try to avoid the benzos specifically for sleep. Now, believe me, I have no qualms at all about using the benzos for panic, anxiety, and all that good stuff during the day. I just don't, maybe it's just personal. I don't know. I don't like to use the benzos for sleep, usually because, the person's already on buprenorphine. They're already on sedating medications. They might already be on a mood stabilizer that's sedating. So I don't want to add another controlled substance on top of it. So those are my pushed against the wall meds. And these are my 4 references. I sent the references to the ECHO staff, so they will all be available for you. And the references are new. So I've got 2 articles for you from 2014, 1 article from 2016, and then I just yesterday discovered an article from 2018. So that's wonderful. And then finally, this is yet another painting of the god Morpheus. Looks a little bit different than the Morpheus we saw in the first slide. And this is a famous painting called In the Arms of Morpheus. So if you all aren't already sleeping by now, I hope that tonight you will be like that lady in the red dress and in the arms of Morpheus and sleeping well. Apparently this painting is held in a private collection, but it's gorgeous. And you can get like a reprint of it from Amazon.com, as I learned yesterday. So that's what I've got.